note, it's just about five of. So everyone, students, residents, faculty joining us tonight, I want to first off take this opportunity to thank you very much for joining us. This is another session of another episode, I should say, in our Insta Live series, Behind the Scenes Conversations with a Program Director or Residency Program Director. I'm really honored to have and privileged to have Dr. Rajiv Rajani coming in to us from University of Texas San Antonio Health Center. Dr. Rajani is a musculoskeletal oncology trained orthopedic surgeon, having done his fellowship at University of Florida in Gainesville. He actually, as you heard us saying, he actually did his medical school training at University of Michigan, and then was at Emory, a little north from us, for his residency training, and then obviously went to Gainesville before joining staff at University of Texas San Antonio. So we are really honored and to have him. He is the Vice Chair of Education there, as well as a residency director, and he's going to talk to us not only about the sort of the application cycle and all the sort of quote unquote chaos associated with it, but also highlight some of the key things and key kind of not findings, but highlight some strengths of UT Health San Antonio specifically. So Dr. Rajani, thank you again for being with us tonight.
Thanks for having me. I appreciate it. It's really, I'll just say you've done a really good job. This is an important niche of education that has been neglected, and using technology to be able to incorporate it, I think, is the best way to connect with some of the students, and it's really great that you're doing it.
Well, thank you very much. I do truly appreciate that, and we appreciate those of you, all of the people who are involved in taking, kind of a proactive role to try to help students around like yourself. So thank you again for that. So what I want to kind of kick off with is sort of tell me how long you've been program director now, and what sort of pearls of wisdom, what lessons have you learned along the way in this journey?
Yeah, it's 5 years now as a full program director, and was assistant for I think 2 or 3 before that. Kind of blends together. I came here in 2011, and my first job out of fellowship. So it's been growth. I've gotten through a full 5 years of classes where I started for their PGY 1 year now to where they just graduated. And I'll say that everyone gets in this position at different stages in their career, and for me it was pretty early. And the biggest thing for me is, it's sort of raising children is, in some ways there's a parallel, is that, my children kind of point the finger at each other, or sometimes they hear, oh, your kid did this, or your kid did that. How come they ran into our yard, or whatever it may be. And you hear about, most of the time you hear more negative things from outside factors and outside people. And in general, I'd say, what I've learned is that if you select the right people and you go through the process and you believe in what you've done, your assumption should be your guys are always going to be in the right, and meaning that there's the truth is somewhere in the middle, as you know, and
right.
And then so you just get to the bottom of it, but more importantly, make the assumption, start from the point of assumption that your people are always in the right, and the other people are sort of misunderstood.
Right.
So you get your people back, as you know, and I think the other thing is, everyone starts at different stages. Some residents come in and they've known orthopedics their whole life, and some come in and they just picked it up early as their 4th year rotation. They loved it, and they just don't have the same background. So everyone's going to start at different places, and so when you try and remediate people or try and get them to improve, I don't know if punishment is really the best way. I don't believe in that. I think it has to be mentorship based. It has to be about how do we get this better, which brings it kind of to where, we brought up Harbaugh earlier. Yeah. And Harbaugh, I really love, and it's my philosophy, knowing myself, it's a growth philosophy. Mm-hmm. And it is about, better tomorrow than today, better today than yesterday. It's his philosophy for football. I actually fundamentally completely agree with it for orthopedics medicine. Right.
Well, that's you touch upon a point that's super near and dear to me, as I know which is the concept of mentorship. And a lot of students will reach out. I'm sure you're finding this too. Oh, will you be my mentor? And it's not quite that. It's not quite so simple. So to you and at University of Texas, sort of how do you define mentorship in your mind, and specifically what sort of mentorship opportunities exist for the residents or for the medical students at, in orthopedics specifically, at UT Health in San Antonio?
For me, the biggest part is, autonomy. We always talk about autonomy. Every program will tell you that we have a ton of autonomy. All our residents operate from the day they walk in, and they can do nails by the time they're at the end of their intern year, right? So, but I think the concept is probably is obviously much deeper than that. And the idea is making decisions, right? So the mentor doesn't make your decision for you, right? The mentor just listens. Most of the time, the job is to listen, absorb, and then really allow that person to reflect and grow from that. And then having people make their own decisions, I think, is an incredibly valuable tool that is very difficult. And sometimes it's sort of like, hey, can you tell me more? Can you give me better advice? And unfortunately, it doesn't always work out that's the easiest thing to do. You gotta really put it back on them to where they make the decisions themselves. So we have a mentorship program. Our faculty are assigned to each resident when they step foot. We try and pair them up with some similarities. A few years ago, I had them do sort of a assessment of what they're interested in from a career standpoint and try to, and that's helpful. I think it is better that way. We're not quite big enough from a faculty standpoint where we can just kind of go with like, hey, who the coolest, easiest people to get along with are.
Right. Right. And I think that you've touched upon a really important point, that notion of feedback, right? And, the feedback aspect is, so students ask me, oh, so how do I know if someone's going to write me a good letter or not? Or how do I, establish this rapport with people? And I said, one of the easiest ways is to actually be proactive and ask for feedback. What went well? What didn't go as well? How can you really, kind of learn from the opportunity at hand, right? I mean, and it's something that even I, in like the operating room, go over with the residents. It's never about just me as the attending or someone as a resident or a student. It's about us as a team and how we can learn from the opportunity at hand. So I think if that's being employed, I mean, that's obviously wonderful. And it sounds like you guys are doing a great job, down at UT San Antonio. So I want to ask you a little bit about how you are guiding students that are approaching you at UT or else about sort of what kinds of things are you looking for in the prospective applicant, and sort of as a generality and even kind of getting more nitty gritty as far as specifics from a variety of the things that are being thrown out there these days.
Yeah, and as you know, this year is obviously unique. There's I could give you an answer for last year, and I'd say it's a very different answer this year. And next year, hopefully, we'll be back to what we did before.
Right.
So historically, what I'm looking for is leadership. That's the biggest thing. And we all talk about the past, previous record is going to predict the future performance. And I would say that's true, right? We're all looking, we all look at scores, we all look at grades. And I think that's, of course, has some relevance in this whole thing, but it's not an absolute. And that's where it sometimes gets confusing for students because they say, well, what's that place's cutoff? Well, we don't have a formal cutoff, right? We kind of look for, you kind of got to be at least in the mid 230s to kind of have a good assessment. Right. But it's not an absolute, right? We certainly have some in the 260s that don't get interviews, and we have some in the 230s that do. It is, and then we have some students that may score really poorly, but they perform extremely well in their rotations. So our home rotators, we have some that don't have the best scores, but they're extremely great students when they're rotating. And when we look at that doesn't mean that they don't get ranked because they have a low score. That means that maybe you bring them down a little bit on the list because of that, but that doesn't mean they don't end up with you. So, when we look at what I'm looking for is the stuff off that, which is the leadership. So have they shown that they can be a captain, a president of a society, things like president of a student group? The same thing that falls in that is first author on papers. We're not looking for somebody that's published 50 papers and say that's, hey, we have a number that we're looking for. It's more the assessment of the idea of you've accomplished something, you're able to show that you can finish things out. And then for me, there's something really important in the personal statement. I'm giving away one of my big secrets here, which is, in orthopedics, it's a very mechanical based field, and we have a lot of engineers that apply to it. I'm not saying that the engineers are the only ones who do this, but if I read a personal statement and at no point they sort of talk about patient care, I have a really hard time bringing that person in. They may talk about, the vectors and the mechanics of orthopedics and putting a nail in and the metallurgy and all this, and this really fits well, and I tore my ACL. If you're not talking about actually taking care of people, it automatically for me goes in the reject pile.
Right. Interesting. So we tried doing a study on the personal statement, and we have not had a lot of a lot of, and you may have gotten the survey or whatever via one of the co-authors, but the we haven't gotten a lot of sort of success in, getting it accepted, I think in part because of the response rate. But, needless to say, from at least a PD perspective, versus the students thought that, oh, hey, it was going to be super important. And then just the differences that we noticed in who spends more time versus what the PDs thought about how important it is. So to hear this perspective, which is something I always tell students, is that, hey, spend the time on the personal statement because you never know what they're going to glean from it specifically. So that's wonderful to hear that that's something you're looking for, even outside of this particular cycle specifically. Oh, go ahead.
I'm sure you've seen that, right? And we see a lot of, again, being in the field that we're in, there's such an emphasis on your score. You're an engineer, you previously played sports. And I'll be honest with you, a lot of those things fall off when we talk about great residents. Yeah. So we're looking for, when you look at personal statement, and I think the same thing we were talking about earlier, it's grit, and it goes with leadership, and that same thing we're talking about, which is your story. And that's your personal statement. It's not about that, that you were an engineer. That may play a role, but it's really about who you are. We're not defining our professions.
Do you think that will play a bigger role in your mind this year? So when you're scrutinizing applications in a cycle where there's no ways, we all know that step one's going to pass fail in a couple of years. Are you and your residency selection committee sort of prepping for what's going to happen, for the changes you're going to have to adapt to in the next couple of years? So, and if you are, what kinds of things are you stressing to faculty to kind of highlight or focus on when they're screening applications or going through them?
So it's a great question. Last year, when we found out about step one, I don't know if it was last year, it feels like last year, it's probably only about 6 months ago, but when we talked about the step one score going away, and what I was going to do this year was blind all my reviewers to their to the step one score, and then I would be the one who would decide. And our selection process, I don't mind, we're pretty open about it, but we have about 12 on the committee. That includes four or five residents. I look at the list this year. We're going to have a meeting next week actually about it, and then we break up the alphabet, right? I look at all of them. Our chair looks at all of them. And then we do it in quartiles. And so each person, so there's 10 other people, they will submit 10 names from their quartile. So you oftentimes have 20 or 30 or 40 people from that quartile, and it's just off of alphabetical. And then from that, I get the list, and then I get to decide from that group that gets submitted through, do we interview that person or not? And for me, I go through obviously I've gone through all of them, so I kind of know what I'm looking for. So that's our selection process, and it's pretty, I think it works pretty well because we end up with a couple that each person picks, and at the same time, I have the final overall say because I have the idea of what direction I want to take the program.
Right. Well, that's awesome to hear. Someone, just while we're on the topic, kind of around the personal statement, someone asked, is it wrong to talk about specifics about your sense of grit in the personal statement, or should it all lead back to orthopedics? Meaning that, should every little nuance in there, be reflective of your interests specifically?
I think the hardest part of the personal statement is we're asking you to talk about yourself without bragging, right? So it's finding that line of saying, here's me, and I'm telling you about what I am, and it should hopefully all be positive, but I don't want to come across as boastful. And so I think anytime you can show that you've had some experience in life, I think one of the most poignant personal statements I ever read was from a young woman who essentially grew up in a completely broken home. It was like they lived, I think the dad was in jail for murder, lived with mom who was on drugs, younger sister lived in, I believe they lived, actually formed, I think she wrote, we grew up in a trailer park was I think her first line out of her personal statement. And to see them incredibly successful through medical school, undergrad medical school, and do well in scores, and just, they didn't have to have a 250. They didn't have a 250 ever, a score that was not out of the ballpark. But you just read that and you say, yeah, that's somebody I want to meet, I want to interview, and I would love to train, right? It's not about you broke your arm when you were a kid and you work with the orthopedic surgeon, right? It's not what it's about.
Yeah, You nailed it on the head with regards to something I really stress to students that, and I say this as, we've all had struggles in our lives, right? And I think that it's not about, and myself included, and it's not about the woe is me. It's what you do in spite of said challenges. How did you get through them? How did you demonstrate your ability to propel yourself forward? And I think if students can really kind of imbibe that notion, then just as Dr. Rajani is saying, that's going to speak volumes about your character, about your grit, your resiliency. All these things are predictive of success in residency more than anything else. And I can't agree with that more. I did want to ask before I forget, can you at least, so I sort of always articulate why step one has been sort of this important thing. And what I haven't asked actually in the past few weeks that we've been doing this is why exactly is step one important? Like when you looked at it, what sort of things are you thinking about when you stare at that score? What is it telling you, and why have you used it at least at UT?
Yeah, it's been, the problem is that when, the study that was done at Harvard and a couple other places that looked at smaller groups, but you look at the board pass rate, and as a program director, we have metrics that we have to perform to at the end of the day, right? If our
Right.
residents are not passing their boards, we care about it. So we ended up following like sheep, right? We ended up just saying, all right, well, you know what? The score does matter, and we're going to use that, and that's the thing that correlated. So guess what? We're going to use that. I brought it up last year with a bunch of students. I think it gets brought up every year at Hillway too. There's a certain smaller faction of program directors and leadership that really don't love step one, and I would say that we fall in that category. I wouldn't say that we throw it out the window, but at the same time, these absolute numbers are insane, right? I mean, I can tell you without doubt some of the most difficult interviews I've had have been with people with incredibly high scores, and you just say, wow, this is not a good fit for us. So you want to find fits for your program, right? And at the end of the day, with the board pass rate overall being really high these days,
Right.
although we'll see where
Right.
they're coming down,
Right.
I'm not, I think everyone's reaching their goals. And again, I can speak to one of our best residents graduated 2 years ago that we've had in a while, and he just fantastic. Had one of the lower step one scores, but he would be somebody you wanted to hire on after when we tried to. Wanted to make a little bit more money, but a fantastic guy, and it's not all about score. So it has been perpetuated. I think it's important to assess from a bare minimum, but you got to keep, you don't have to go crazy on it. That's my opinion.
Right. So, and that's great. I'm glad I asked this question because, I know there's obviously lots of metrics out there floating around, stuff that I've also shared because it's obviously, something to be cognizant of. But ultimately, it is important to take your step score in the context of your application and to talk to the faculty around you as much as you can, or to reach out to folks like us who can at least give you a sense as to, hey, how is your application from a competitive, standpoint? And the board passing is something that has been called into question like all the time, because at the end of 5 years of residency, you've got to take this major test, which, you think step one's hard. The orthopedic boards are, it's pretty hard too. And, it's another 8-hour test. So, think of it from that perspective, not as a, hey, we're just trying to weed people out. It's a way to, again, ascertain who can also perform academically. But it's, again, one piece to the puzzle. One question that I always forget to ask, I wanted to make sure I brought up this time, is reapplicants. So folks who did not match this past year, who are, either doing a prelim year or doing a research year right now. How do you view them? And do you have any suggestions or piece of advice as they move forward this cycle?
Yeah, I think it's a tough position to be a reapplicant because we're all sensitive people. We all have our own level of ego, and when it gets hit that hard, it's a shock to people, and I think it's just, we all have different reasons, right? Some people apply really late. They decide later in their fourth year they didn't establish their
Right.
experience in orthopedics, and some are, from a numbers standpoint, which you can't change. Some are in a school, they didn't have any mentorship, they didn't have a home orthopedic program, things like that. So there are a lot of variables that each individual goes. if one of the people we interviewed one year goes on to not match, we'll often offer them an interview. The hard part is trying to get the ones that we didn't interview. There was a reason why we didn't interview them the first time, and we have our own criteria, and every place does. And I think that's hard to kind of say, oh, we're gonna interview somebody that we didn't do last year.
Right.
That was a reality, But people that we did interview and we had on our rank list somewhere, my general feeling is they will see what how they changed over a year, but at the same time they may fall into a similar spot that they were last year, which year to year you don't know where your rank list is going to go. Some places know very specifically because they put they know everyone's saying, hey, we're ranking number one. We don't do that. We rank as based off of our own opinion, not off of feedback we get.
Got it. A question just came up is, with regards to letters of recommendation, do you prefer them to be knowing that you're part of CORD, do you prefer them to be the standard letter of rec? Do you prefer the narrative? Do you prefer the SLOR that's going around this year? Or do you prefer sort of a kind of a combination of both the narrative and the SLOR, whether electronic or on its own?
Yeah, disclosure, I am a part of CORD. I'm on the CORD subcommittee, academic subcommittee. So me personally, I like, and what I do for our students is I use the standard letter of recommendation form with all the different 1 to 100 spots. And then I like a small narrative. I don't need the recapping of the CV, which is what we've all despised for years, but I want a little small narrative. And I do like, the biggest problem, and you know this, is we get they've looked at the letters of rec here and everyone's ranked to match everywhere you go. And right. Every student gets that. I don't do that. All my students are cringing now because of that, but we've done well at our matching, but I don't do that. So I think it's really important. There's a lot of pressure on program directors to not do that. But I think people respect my letter because I don't do that. I think they actually understand there's a difference in the higher end versus the middle end or lower end.
Right. Do you think that especially this year, with there being obviously no ways, there's a lot more probably the kids without home programs being affected. You probably just saw the question pop up. What about letters from outside of orthopedics?
This year is okay. We've made the agreement. We're letting our students do 2 months home rotation so they can effectively get 3 with not a lot of trouble. But I absolutely think, this is a tough year. And I think Bill Levine's brought it up. He was sort of the first person to bring it up, that if you're not from one of these programs that has home programs that don't have these, can't get letters of rec and can't rotate, it's going to be harder this year. There's no question. But one thing to remind people is that if you look at the numbers and again, if you're a U.S. MD program, the match rates are really high, and DO programs orthopedic programs have grown in general, so those should be pretty good too. I don't know the exact data, but they're pretty high overall for U.S. grads going to orthopedics. Yeah, IMG is much more difficult, right? And I think that's a group in this year that would really be if you're going to look at the ones that have the lowest numbers, that's going to be that group.
Right. Do you think that with regards to, I talked with Dr. Harrington just a couple of weeks ago, we were talking about numbers of applications and so on. And this is going to be sort of one of the last questions I asked before I pivot to the showcasing UT San Antonio. Are you making suggestions, or do you have sort of criteria you've been using even outside of CORD or the AAMC data or recommendations as far as, hey, how many programs people should be applying to? Do you think it's better to over apply? Do you think it's better to sort of under apply? Do you think it's really something that students should be working on with their faculty mentors as much as possible?
I like the spot you're putting me in. It's a challenging question. I'm glad you're asking me a tough question. Hey, you know what? I like it. Yes, that's what we're here for. As you know, there's a recommendation that we push our students towards applying to less programs and giving them that sort of there's diminishing returns. Right. I would tell them I generally agree with that. There is diminishing returns. The problem is, as you know, we haven't fully identified which programs those are. And that's where these students need to, we need to look at things like, okay, just being objective, has students from our school, have they gone to that residency before? Is there sort of this pipeline, as we would talk about, geographic relationship? I was a student at Michigan. I use myself sort of as a microcosm, and I don't want to say I'm representative of everyone, but, I'd look at this and I'd say, if I'm a student from Michigan this year, and I'm applying, and I apply to San Antonio. Number one, what are the odds of me getting an interview there? Two, am I going to go there sight unseen? If I'd never
Right.
visited there. So I think this
Right.
year there's going to be a lot of this sort of regional strong preference. So be very strategic this year, in my opinion. Be a regional applier, apply everywhere in your region for sure. If you weren't doing that before. But then realize that there's going to be this year really diminishing returns unless you have a strong reason to be somewhere. I'm just advising. I don't know if it's worth it. You know, and again, for them, it's an extra click, an extra dollars in the drop of the bucket. So I absolutely understand.
Right.
I get it.
Right.
But at the same time, it's tough. Tough to see.
Yeah, no, definitely. And you know, I know there's lots of conversations, discussions on all sorts of social media pages about this, you know, about this issue specifically. But, and I would certainly, you know, I think, and what I've been encouraging our 18 is to, it's not a, I have to work with you to sort of be cognizant of where you stand so you can best sort of strategize how many you should be applying to optimize your chances of matching. I certainly don't think that the onus should be on students alone. I think we as faculty and, you know, advisors and mentors, I think that's certainly helpful. But yes, but it's definitely a tough thing, and there's no perfect answer. You know, bottom line. Do you?
Can I follow up on that with a comment?
Yeah.
You know, our med schools, you know, we usually have somewhere in that 10, 15, or 15 to 18 range. This year we have 10, and 2 are military, so they may fall out separately altogether. But they've done a Google document within themselves to look at places, and they've done this for the last 5 years or so. They've identified, hey, here's my sort of top choice for where I would have rotated, my top 1, 2, 3, and so they have it. And so they don't overlap because, as I would say, a program, you were talking about Mel Harrington at Baylor, you know, if 10 of our students apply there or 15 of ours apply there, Mel's not going to interview all 15. It's just not going to happen, right? And so be strategic in this sense that, you know, identify a place you really like, and he may interview 4 or 5, maybe, you know, in that range. Choose those 4 or 5, and then, you know, the 4 or 5 apply to Scott and White and you know, in Austin, whatever it may be. That are regional. Yeah. So I think hopefully, you know, I think there is a lot of mentorship and guidance on this, and hopefully I'm giving them good advice.
I know, no, you definitely are. So 2 more questions before I sort of pivot to the UT stuff that have come up from some folks here. With so many great applicants, what factors do you tend to see in applicants that you do not rank? So those who maybe fall off the bandwagon for whatever the reason may be, what reasons are there?
Yeah, it's a good question. You know, we ended up, so just I have a very open disclosure approach on mine. We historically would interview around 64. We had 6 spots, so it's about a 1 to 10 ratio. Usually it ends up being a 60 to 64. And then we would end up ranking in the last few years since I've been in charge, we end up ranking somewhere around 50 to 55. So pretty good odds you're going to get on the rank list if you can interview. What the people that fall off typically are, you know, on paper, people look great, and they, and then when they get to the interview, that's when you really fall off. I do believe truly that once you make an interview for a lot of places historically, and I'll talk about this year, once you make the interview, you usually at that point, it is really for us a pretty level field. You know, somebody can jump up way up at that point because we've sort of done the hard work up front. This year, it's going to be interesting. You know, we haven't fully discussed how we're going to do our interview process. I have feelings about it. We have a meeting on September 4th to go over this, but I think it's going to be focusing on, again, getting to the bare essentials of how does this person present themselves? Are they, how do they engage with you? Or do they come across as unteachable or disinterested? You know, as much as, you know, the basics of interview process. So those are the ones that fall off typically. So, you know, when it's a 90%, once you make it to the interview, kind of tells you most of those people we feel pretty comfortable with.
Right. You know, it's a great point. I was actually on the phone with Dr. Levine earlier today, and after I got home, and, you know, we were just talking about, it's hard to quantify this, you know, fit factor, or how, you know, a student who may look great on paper, how they jive with the program. And while they may be a great orthopod in the future, they may just not be a great orthopod coming from that program in particular. And I think that's something that often goes, sort of understated in terms of how programs can best evaluate that attribute of it. Because the application is one part of it, but just like we keep saying, step one is not the entire story. Neither is the research, neither is the AOA, all this stuff isn't the entire thing. So you certainly have to keep this other stuff in mind. Someone asked about, location. What if you've shown location isn't an issue based on prior experiences? Does that sort of play a role in your mind in terms of, hey, I'm trying to engage outside of wherever I'm in med school at?
Yeah, it does. I use myself as an example. I took a job in San Antonio in 2011 without ever, I visited here for my one interview for one day, and then it was raining, which is a little unusual in San Antonio. And then my wife came for 2 days or 3 days, and I remember drinking margaritas on the Riverwalk, and I was going to go back to Michigan, actually, not to a place called William Beaumont. And that was my dream job growing up. I literally had it in front of me. And my wife and I were sitting there, and I said, I'm a little bit surprised. I like it as much as I do here. It's really people for us, and I'm kind of going into our program a little bit more here. San Antonio is a fantastic place. Like I've been here almost 10 years, and I have no ties here to when I got here, right? And I love it. And in general, I would say everybody loves it for a variety of reasons. But that's hard to gauge if you're not familiar with it. So geography does matter. It matters to the program directors. It matters because there's nothing worse than having a very, very, very unhappy resident where they're just like, this is not the right place for me. I'm in the wrong place. It affects their work. It affects their personal life. It affects their interactions, all that. So we want people that really are really happy about staying, not just like, oh, I would go there because of the program. You want people to engage in their community. So if you've had an experience that you said, all right, I'm from, I lived in New York for a year or two, and I like the environment, right? If that's your personality, then do it. I wouldn't, I think one of the important things is being very honest about your personal statements. A lot of people may ask for these sort of, why our program this year, because they're not going to be able to assess it otherwise.
Right.
And I think that's going to be, you have to be very honest with yourself in those programs, because one of the worst things for you to have is to match at a place you just don't want to go. Like, you're just not going to be happy there. I know it sounds silly, and it sounds very sitting in now that I'm on the other side of the fence, that like, hey, we just want to match. I get it. Yeah. But I think you should just set yourself up to be honest up front.
That's a wonderful point. And so with that in mind, kind of I pivot now and kind of incorporate a question that was just asked. So what are ways that, folks who are from outside, if you're coming in from the Michigan, you did medical training in Michigan, end up in San Antonio, how do students now, without these aways, engage programs, outside of the regions that they are at? And does San Antonio have opportunities for students to engage with the program in some way, shape, or form?
Yeah, so, just kind of going back, I talked at AOA about virtual rotations a few months ago, and, I have mixed feelings about it. I think that what we can use it for is the relationship building, which is such an important part of, does the student relate, can they get along with residents and have their questions answered? Because that's a lot of what it is finding out, okay, what's the jive? What's the culture? How do people feel? How do I interact with people? And that's, I think, the more valuable part of these virtual rotations. I think any form of assessment of a student through virtual rotations, I feel strongly against, because that's, what's the worst thing when you're a student, right? You worked one day with a faculty member and they said, they were okay. And you're like, I just spent an hour with you. There's nothing worse than that. So trying to assess through this mechanism that we haven't figured out is, to me, a very, very inappropriate use of virtual rotations. But I think it is important to build the relationships and say, hey, okay, are these people that we get, that would fit in our culture, that we like their personalities? Are they? Those kinds of things, which I think are more of the interview things that I was alluding to earlier, rather than the virtual rotation. But how does a student express interest? Involve yourself with the virtual rotation with us. I think it's one. We're going to have a resident Zoom meeting with just residents. I won't be involved, just for every student that wants to be involved sometime in September. You can follow us at our new Instagram, Ortho. Let's see, so Ortho Utusca. Let's see, I have to look it up. It came up. We made it today, I think.
I think I saw it.
UT Ortho, UT Orthos, UT San Antonio Ortho. I got to remember it. Just came up today. But or our Twitter, I got that UT Health SA Ortho. That's what it is. UT Health SA Ortho. And so we're going to have a Zoom with our with all our residents. We're going to have another one that's, again, not for just the invites for interviews, but for everyone, with some of our faculty, key faculty. And then of course, you kind of asked me to talk about like things I'm working on. I'm doing this video, and just like most people, I really want to showcase our program and show off, and so people have the information that they need. So I'm learning how to do video editing, and I'm doing it myself. I'm excited about it.
That's awesome.
It's a new project. Yeah, I like it. It's exciting.
So what would you consider, obviously sounds like the residents have a great, residency director in yourself. What kinds of things would you consider are the strengths / highlights of the program at this point?
Yeah, I mean, I think one is we have diverse training experience. Texas is an unusual state, so most people are familiar with, so for example, I was at Michigan, and as a med student, it's probably changed, this has been 15 years. You worked at the University of Michigan hospitals, and that was your hospital. Mm-hmm. Texas in general is a little bit more different, is that we don't yet, although in 2025 we don't have our own formal hospital, which means we aren't tied to the downsides of having your own hospital, and the upsides of it, of not owning it. We work at University Hospital, which is really our county hospital. We work at Methodist Hospital. We work at our outpatient surgery center. We work at the at Methodist Texan. We work at other ones that are very close, VA. So we have a lot of different learning environments, which to me, I've always said our goal in residency is to prepare people to go into practice. It's the simplest way of explaining it. And when you go into practice, everyone's practice is very different, right? You can go to an academic center, you can go to you can work in a smaller community hospital, a bigger community hospital. So we try and give that really wide breadth of experience. It also means most of the time we're not waiting on, my block time is this on that such and such date, or they don't have time for me to add this case on. If you see a patient in clinic that has trouble, has a wound infection, which never happens to us, of course, but if you happen to see that unicorn, you don't have to wait for block time at this other hospital they can't get me tomorrow. You go to this other hospital. So we have freedom of movement, freedom of opportunities. And that's why when we had this sort of lockdown of cases, it really allowed us a lot of freedom to retain the clinical volume. So that's one of the key things. So the training experience is pretty diverse. We have all the specialties in our city. We train in our city. We try and keep people geographically right here. We don't want them going to a different town. And then one of the really cool things is a couple of years ago, we developed this 4th-year elective time, which we had electives previously, and then because of a variety of factors, we ended up losing that time. We had switched it over, but we kind of got it back. And so we've actually coordinated where we can send, and this year, unfortunately, because of COVID, we couldn't do it, but we've sent 4th-year residents to Brazil, Switzerland, Thailand, and I think Italy, for 2 months, essentially 6 weeks. And
that's awesome.
We give them a stipend to kind of cover at least most of it, not all of it, but pretty much most of it. And one of our faculty goes and lectures there at the same time.
Wow.
It's a really kind of cool trip.
Wow, that's awesome. I was like, can I sign up?
Yeah, I think they really appreciate it. We want our residents to think bigger than just here.
Right. That's absolutely wonderful. Tell me what's the operating experience like? And I know students obviously want to come in day one with the knife. Yeah. And I remember hearing the stories about Emory, and you can, sure. Day one, you were going to be like putting a tibial nail in. And I remember thinking like, I'm not sure I can handle that, when I was going through the process. But so is it more graded autonomy with increase in residency? Is it increase in residency training? Is it pretty hands-on from the get-go? What's sort of the kind of approach y'all take?
Yeah, it's funny you ask. So I went to residency at Emory and I rotated there, and you'd never guess where I rotated as my other way, is where you're at, Miami. So
Miami? Go figure.
Those are my 2 away rotations. Say hi to Sheila for me, by the way.
I sure will.
And so there are certain programs that are well known as sort of being these places where you go and you get the autonomy and it's real. Right. I think it's pretty clear they know it's here. But I really believe in this idea of graded autonomy. I really believe supervised autonomy is the concept that I use. When I'm on call on trauma, I'll use this for a perfect example. I get called and I know my residents well enough to know what they can handle, and it's up to us to make that decision. A lot of places don't have that freedom where they're sort of forced to, your attendees have to be there. They have to. I choose in the cases I go in. And in general, if there's hardware going in, I'll go in. I don't think I've scrubbed a trauma case in, I don't know, I can't tell you. And that's pretty typical for our attendings. We put our PGY1s when they're on orthoplastics. It's a plastics rotation, but it's a lot of ortho. They run a room by themselves. Now, that's a lot of times it's washouts, things like that, but they're in there and they're making the decisions. They understand how to set up the OR. They're ready to do it on their own. Twos, we expect them to be able to handle ankle fracture. By the time ankle fractures, tibial nails, they better handle it by the time they're two. If they're not, we got to speed them up a little bit. Hip fractures for sure. That's a full expectation. You get to 3, 4, 5. It's about understanding how to run a system, right? Running the team, running all that. We don't want our 5s to feel like they have to be in the room, right? And they have to take the 2s through. We want them to give them a little bit of decision making. One of the ways we know to do that is a lot of places have increased their number of fellows. We've been very slow and intentionally resistant to having a lot of fellows. We have 1 trauma fellow for 4 faculty. Just started as the second year of that. We have 1 sports fellow, but it's really shared between the community and with our UT system. And then we have 1 shoulder elbow fellow who, again, is shared within around 4 or 5 faculty. So the rest of it's resident experience. And I think that's really, really helpful to maintain that. And again, we don't have any plans to increase.
That's absolutely fellows. Right. Are you guys expanding residents? I mean, you said 6 at the beginning. Are you guys in the thick of expanding further?
We got approved to go to 7, actually. So we applied for that in the winter. We were approved to go to 7. As I tell everyone, and even our residents, is I'm still working through if we're going to go to 7. I want to see how the numbers work out over the next year or the next few months since in COVID cases, and making sure that we're back to normal. We're about 90%, but I want to see it 100, 110% after that, right?
Right.
And again, it's a pretty graduated process, right? You don't all of a sudden have 5 new residents show up day 1. It's PGY1. And most of what I've done hasn't changed the clinical volume. That's one of our concerns is when you keep adding people, you're subtracting from the clinical experience of others. But if you look at it, it's really, one of the things I think you wanted to ask me maybe about how are you going to change the program or how you're changing it.
Right. That was actually my next question, literally.
Yeah, I'm just talking. Sorry, bud.
No. You're good.
And so going to 7, I think changes, we're adding PGY 2 year. So 1 is basically, it's the same 12 months. Although we moved them on to recon, they do tumor right now. I'm going to move that 1 into a second year of tumor rotation because I think in terms of it's a little early for them to do tumor. And then 3rd year, they do a research block. 4th year, they do a QI versus elective, which is what we were talking about, truly elective time.
Right.
And then 5th year, I'm fortunately I have about 5 years to work out the full details, but I want them to run a sort of independent-ish clinic and independent sort of experience where they are ready to go and learn about the nuances of coding, learn about how to practice management, leadership, and running their own clinic with some supervision, of course, because that's required. And of course, making the decisions for surgery. And that's sort of their 5th year rotation. It would be the new one.
That's awesome. And is this based upon suggestions and feedback you've gotten from the residents previously, or is it based in part from like just a programmatic standpoint, y'all are, hey, how best do we make adjustments to improve upon the current system at hand?
Yeah, it's a combination of both. You don't want to take a strength, which is our clinical experience. And I really do believe when our residents graduate that they are fully capable of going into private practice without having to do a fellowship. I really fully believe that for at least all of them. They all 90-something odd % still do fellowships, of course, and because for a variety of other factors. But I think they really are capable, and I feel comfortable with them. When we look at what we want to go is you don't want to take away that clinical experience to compromise for focusing on research and QI and things like that are important from a programmatic standpoint as you're learning, but not necessarily individually. We do require them to have 1 publishable paper by the time they graduate, but I look at them having something called scholarly activity as a term. I want them to have over 10 pieces of scholarly activity. And people say, I want them to do 10 research. No. It means like maybe they presented it a couple times, maybe they got a grant, that counts as 1, they published it, that's another 1. And then you do that 2 papers, you've easily made it. But then not only that, there are a lot of other ways to do the things like that. They serve on a committee of some kind. So I say 10 pieces of scholarly activity, and I include all that together by the time they're done. It's sort of my expectation. Um, and I think you were asking about the information, or how do we make this decision to change the rotations. The other aspect was every Monday I meet with our student or residents, a different class from 5 to 6. So yes, it's a weekly meeting. I meet with our PGY1s. The following week it's PGY2s. Following week PGY3s, so on. And it's for up to an hour. Sometimes we do it in 30 minutes. But it's to keep them abreast of what's going on from a program standpoint, and then for me to get the feedback from them, because when you have at this point 30 residents, and you have them on 7, 8 different kind of rotations, there's just no way to stay abreast of what's going on without that feedback.
That's absolutely awesome. What is with obviously sounds like a very busy clinical services, obviously lots of great hands-on experience. What's the chemistry like amongst the residents? What's the chemistry like amongst the faculty? And then lastly, the interaction between faculty and residents as a whole.
Yeah. No one's going to come on here and tell you it's bad, right? But it really is.
Right.
There are places that are notorious, that are just known for having that good camaraderie. And I trained at one. I think Emory had fantastic camaraderie with a lot of the residents and faculty. And I think it's very similar here, right? It's very similar to sort of to Miami. There are a lot of parallels of the places I've been and the culture. It's you work hard, you get along, everyone works hard, you accept it, you don't gripe about it, and you're fortunate, and you believe really that you're fortunate to be training there. And yeah, you're tired. It's not. I want our residents to be a little tired. That's just part of being a resident.
Right.
And I think that you're not getting enough training if you're not. So the camaraderie is great. When I got here, we had some older groups. Kate Wilkins is a well-known pediatric orthopedist, along with Rockwood Wilkins, as you all know. And Dr. Rockwood is still around. He wasn't operating, but he was still around. We had a lot of older, more professor level, and there were a lot of assistant level new faculty. There really was a deficiency of that middle ground. There were maybe 1 or 2 in the middle. And over time now, almost 10 years, we now have the assistant professors are still kind of coming in, but we have a group of about 5 or 6 associate professors, which is really the meat of your training. And I think I really do think that's the most valuable. They figured it out. They know what they're doing. They're not trying to steal cases from you.
Right.
They're getting the clinical volume. And then we have a few professors, right, but they're still the ones that are practicing. So I think that's been a nice dynamic change and has been really helpful for the residents and students.
That's great. So do the residents get along themselves? Are they're pretty like, is the chemistry pretty high from what you can see overall?
Yeah. Yes. So I'm going to tell you something that I think is very unique. So I believe in the idea of diversity, and I don't, that it's a very hot button topic, but at the same time, the idea of diversity to me is having people from different personalities and different experiences of life and different cultures and different race and all that. I mean, it's all of that. And the hard part is getting diversity, but having people get along. And I'm going to say it goes back to your who you are as an individual. And I can tell you, I'm incredibly proud of our residents. I think they absolutely embrace it. It's, I always tell them I don't want to give them too much credit because I need them to be a little bit afraid of me, but they get it, they get it. That's the real world is going to be, it's not, it's diverse. You're going to need to have it. So I want them to be prepared for all that and working with people, most importantly, because that's something that in a lot of surgical fields historically, and certainly in medicine, we really have not had to solve that. And I think it's important to figure it out now.
No, that's absolutely, I think another great point. And, you have to, and I say this in retrospect, that if, the challenges you go through in residency, and it sounds like the experiences that your residents are getting in San Antonio, they prepare you for life and practice, and I tell my residents down here in Miami that, listen, there's no post-call when you're an attending. You don't have the luxury of like going home. If you were on call in the OR, you have to go to clinic or the OR the next day.
That's what it is.
It is what it is. Exactly right. And so I always kind of say that residency is boot camp of sorts, and to kind of get you ready for the challenge and trials and tribulations that real practice is. So the more wet you can get your feet, and more sort of all in you can be, then that much more prepared are you going to be down the line when you're facing tough cases or tough situations personally, professionally, academically, whatever it may be.
That's right.
And it sounds like they're absolutely getting that sort of training and more, and maybe a trip to Italy from what it sounds like, with obviously a lot of work going behind that,
Right.
you know, at San Antonio. You know, I want to open up, but as we're kind of nearing an hour here, I want to open it up to some questions from the audience. If anyone has any questions to ask Dr. Rajani, you know, before we finish out with just about anything. And one thing I wanted to bring up that I think you kind of touched upon earlier, but just to highlight, are y'all interviewing osteopathic students and or IMGs? Have you interviewed them in the past? Are you planning on interviewing them now? And will you continue to do so in the future?
Yeah, it's a tough question. Yeah, a good question. We had an IMG that graduated just a few months ago, right? I mean, excuse me, not an IMG, a DO, excuse me, just graduated from our program. Fantastic resident, right? I have no qualms. We haven't interviewed IMGs in the last, you know, since I've been in San Antonio, really since 2011. We haven't interviewed IMGs. DOs, yes, on occasion we absolutely will. It tends not to be where the focus is. We have a pretty robust medical school here, so we end up with usually 2 or 3 that are coming from our school. You know, as we go to 7, I think it definitely changes sort of how we look at our numbers and who we're our pool of applicants. So I think DOs, definitely it's a possibility. I would say it's a unique individual, obviously, that has some specific relationship with San Antonio would probably be the best kind of person. And IMGs, not typically, no.
Okay, got it. Well, you know, first off, I want to thank you for all the, you know, the wealth of information, the insight, the wisdom. It's absolutely, you know, it's super appreciated. I do want to, you know, tell everyone, hey, listen, if you haven't, please check out, you know, UT San Antonio and their program, whether orthopedics or otherwise. Dr. Rajani is absolutely amazing. You know, you're doing a great job for your residents. I couldn't, you know, it's a real privilege for me to have you on tonight. If there's any other questions or anything, you can always feel free to connect with me, and I can certainly send questions to Dr. Rajani if you have them about his program in particular. But thank you again for your time tonight. This recording will be available in the next couple of days on the OrthoMentor YouTube channel. So go ahead and, you know, check it out if you have, if you want to kind of revisit certain topics that got brought up tonight. But thank you again. Have a great night. And Dr. Rajani, thank you once again.
Oh, thank you. Yeah, I appreciate it. And again, I think you're in a great interview. I think tough questions are always the important questions. It doesn't get asked that often. And you need to put us on the spot. That's part of our job here, to be able to come up with the answers.
Well, you know, it's at least a way to kind of open Pandora's box in some ways of, you know, bringing some stuff to light that I think is, you know, we hope that we can kind of raise some transparent or make some, you know, be transparent about. And so I do appreciate your candor and the information for the students more than anything else. And I know that they appreciate it too. So thank you again and have a great night.
Thanks. You too. Take care.
All right. You too. Stay safe. Thanks again. Have a good night.
You too. Thanks.